got the slides up. So we do go ahead to the next. I'll just cue you up. Yep. Thank you. So we have some FDA and NIDA funding for this, and keep going. And I wanted to use the same talk, which is why I didn't even change the initial coverages, to what we talked about in ASAM State of the Art, which is the annual conference where clinical people tend to get together for figuring out kind of what's new, what's the review. And so just as some learning objectives, I really want to talk about adult diagnostic criteria and evaluation within the substance use disorder comorbid populations, some characteristics and methods that we use to reduce stimulant misuse, some of our work with trajectories of stimulant use, looking at MTF data and other data, and then some discussion about what happened during COVID with stimulant diversion. Next slide, please. So just as a reminder, because if you're not in the ADHD space, sometimes helpful to have a diagnostic reminder. So ADHD, per the DSM, right, has two major categories: inattention and then impulsive hyperactive. And if you go to the next slide, in adults, the diagnosis requires that there are 5 or more symptoms per category for at least 6 months, but that the symptoms started before the age of 12, and that impairment is experienced in at least 2 settings and not accounted for by another diagnosis. So, really having PHQ-9s, toxicology markers, and biomarkers are really helpful when you're considering starting someone, particularly with comorbid substance use disorder, on a medication. Next slide, please. We all know there's 3 types: inattentive, hyperactive, combined. For combined, again, it's the 5 symptoms or more per category. In kids, it's 6 or more. Next slide. This is really a slide of global prevalence of ADHD. And in kids and adolescents, if you look at the global literature, it's 6 to 9%. In the US, it's 10 to 15%. In adults, you will have residual ADHD in about 5%, 4.4%. And it is, we believe, a neurodevelopmental disorder that responds well to treatment. Next slide. Thanks, Angela. So let's just talk about some risk factors. We know it's one of the most heritable diseases. So if a parent has ADHD, the child's rate of having ADHD is upwards of 50%. The mean heritability factor is about 0.77. And just to kind of give you some point of reference, that's about the same degree of heritability as somebody with a BRCA-associated breast cancer or with schizophrenia. And so in these assessments, it's really important to ask who in the family has ADHD. Interestingly, there's some prenatal and perinatal factors like exposure to valproate, substances, Topamax, smoking, low birth weight, preterm deliveries, and then if there were reduced APGAR scores. Oftentimes when we're seeing patients later in life, these are hard things to kind of get at, in particular if parents are deceased. The other childhood factors that are really important is if there was severe early deprivation or traumatic brain injuries. Next slide. And this is a reminder that ADHD, as people age, really changes. And so often in college-age students, we're seeing academic failure, not coping with routines, occupational difficulties, a lot of anxiety and low self-esteem, and substance use disorders, alcohol use disorders, unintentional injuries. In adults, this is where it really manifests: is mood instability, low self-esteem, relationship problems, difficulty with planning and completing tasks, right? People start having families and life gets more complicated. inconsistent parenting styles are often seen. And then, of course, alcohol and substance use disorders. Next slide, please. So even though we may have fewer symptoms, there's often greater consequences in adult ADHD, and the impairment in quality of life, reduced employment, driving impairment, disrupted relationships. These are major issues. About 87% of adults will have comorbidity, 60% will have depression, substance use disorder in 57%, and we'll look at some of those studies. Anxiety disorders are highly common. I think the thing that is most important is that if you have ADHD alone with no comorbidity, mortality increases 150% over general populations. With two comorbidities, it's a 450% increase. And so ADHD in and of itself is challenging. Next slide. So who gets missed, right? Who are we seeing in adult? In general, high IQ and high achievement often missed till later in adult. Women, there was one study that showed in women with ADHD, it's a graph related to IQ. And if the IQ is 120 or above, they typically to get diagnosis was at like 45 to 50 years of age. People tend to have reasonable coping strategies that they've developed, and professions that rely less on organization and attention, sales jobs, fast reaction time, surgery, interestingly can be one. Other people who are in high interest topics where they harness the focus of the hyper focus, right? The golden nugget in ADHD can also compensate pretty well for times of inattention. And then there's masking with comorbidities. Next slide. So about 23% of adults with substance use disorder have ADHD. So about 1 in 5 who walk in clinically to see us will have ADHD. However, 55 to 57% of people with ADHD will have a substance use disorder, right? So from really, those severe childhood ADHDs, about half of those will develop a substance use disorder. Next slide. So what about treatment? Well, in adults, male to female ratio is equal. Treatment response in adults is about equal to that in kids. So good response rates. Regimens are best when simple and structured. But really interestingly, just like in kids, long-term adherence to medication is poor. Next slide. So what about substance use disorder courses associated with ADHD? Typically more severe substance use disorders, higher rates of other psychiatric comorbidities like conduct and antisocial disorders. We have less remission from substance use disorders, but that's a little bit of a loaded statement. In remission definition has changed as the field has evolved. People tend to have longer courses of substance use disorder and lower retention in cigarette and substance use disorder treatment. Next slide. So some diagnostic dilemmas, right? We have overlap of symptoms with intoxication and withdrawal. We have neuropsychological deficits that can be transient or permanent. And I haven't seen data on this though clinically, as especially in healthcare providers, I'm seeing a fair amount as ADOS has evolved for neurodivergent spectrum testing. Many people kind of either not diagnosed with ADHD or diagnosed with ADHD who probably are more on a low needs, high functioning autism spectrum. Reliability of retrospective report can be challenging in individuals with substance use disorders. So if I am thinking about, and most people who do a lot of treatment with this, when you are thinking about starting a stimulant in somebody, especially with a substance use disorder, especially if the first time they're starting treatment is 8th grade or after, I will often require a release of information to talk to a sibling, a parent, somebody who knew them from childhood to try to establish that this was a neurodevelopmental disorder for the person because the risks are so high. And then, really using standardized questionnaires has been important. And then things like test of TOVAs and neuropsych testing when appropriate. Next slide. So our Canadian colleagues, they always feel a little bit ahead of us. They actually have wonderful practice guidelines. This initial version was published in 2006. They're updating theirs currently to include the kind of substance use disorder population and treatment. And then if you go to the next slide, APSARD, which I think is currently meeting or just met in California, is the American Professional Society of ADHD and Related Disorders. They announced in August of 23 that they're going to develop and publish the first American guidelines specific to ADHD. And there are a number of really good people on APSARD in the ADHD substance use space that are working on this. So next slide. Let's talk about double-blind studies of stimulants to treat concurrent SUD with ADHD. There are about 6. The majority showing no overall improvement in substance use disorder. 1 study trending to improvement. 2 studies showing benefit in reducing ADHD symptoms only on some measures, but not others. And it was Francis Levin's study that really showed improvement in ADHD and substance use disorders using high-dose methylphenidate XR well above FDA recommended levels. No serious adverse events in these studies, no worsening of substance use disorder, and no evidence of diversion, at least in these randomized controlled trials in a controlled setting. Next slide. This is Tim Willen's data, who's one of our co-investigators out of Harvard, and they looked at, these are basically 171 treated college students with ADHD, and really looked at retention in treatment. And what they saw was improved short and long-term retention in outpatient substance use treatment. However, it was retrospective, naturalistic, and study design really limits causal inference within this framework. And so, some food for thought, I think. Next slide. So in terms of within the context to substance use disorder, when ADHD treatment should be considered, right? So, when you talk to Francis Levin or Tim Willens, right, like there's some kind of general consensus in expert opinion. Again, the data is pretty scarce. But if the substance use disorder is mild and current, typically we treat ADHD concomitantly. So, right, like a mild, maybe a moderate substance use disorder. If it's a more severe, we tend to address the substance use disorder first. And then in the context, often we'll exhaust non-stimulants, or if it's really clear, we'll use a prodrug extended release stimulant, such as Vyvanse or Concerta. I almost never prescribe immediate release stimulants for people with substance use disorders. I can think of one patient that I currently have who's been really takes his medication, really needs it to function, and he is the rare case in that he also has a concurrent active substance use disorder. But there's a lot of biological markers because the risk for him without medical monitoring, just like if I were prescribing someone with diabetes, insulin, I would follow their A1C, is important for him from his own and for me, because he's a polysubstance use disorder patient, but he's now graduated college, moving forward on his life, and has employed a lot of strategies in cognitive behavioral therapy. Okay, next slide. All right, so let's just talk about stimulant misuse or non-medical use of stimulants. And just next slide. As a reminder, in 2022, when we looked at some MTF data, lifetime non-medical use of prescription stimulants, defined as either using somebody else's or even using your own outside the context of how it's prescribed, prevalence was 5.3 percentages. Remember, that's higher than prescription opioid misuse, tranquilizers, or sedatives. And so, as many of us in this space know, stimulants are really kind of the orange is the new black, right? Next slide. A reminder that prescription stimulant misuse peaks at age 21, and it's about 10% of the population that reports. So these are lifetime reports based on SAMHSA data. Next slide. There are about 120 studies that look at stimulant misuse and diversion. Most were done in college students. It's about 80% of those studies. Again, in these studies, it was a 10 to 20% prevalence estimate. 65 to 85% of stimulants were diverted from friends. So, a lot of the medical community, which was very stigmatizing, didn't want to see patients, but really that doesn't make sense from an evidence-based standpoint. And so I think this is data that's worth sharing with our colleagues. Who is it? Next slide, please. What are the characteristics of individuals who misuse prescription stimulants is worth thinking about as well. Next slide. When looking at the NESDA data of adolescents and young adults, so this is 2015 to 2018 data, cognitive enhancement as the motivator, as we saw increasing age. So at age 14, cognitive enhancement had a rate of about 40% as the motivator, but 71% by the age of 25. So not surprisingly, college students endorse more cognitive enhancement motivation than those not in school. Presence of any prescription stimulant misuse was linked to more substance use, suicidal ideation, and other psychopathology. And it's worth pointing out that one take home is that prevention in adolescence, as well as screening and intervention among adolescents and young adults, from our perspective, should be considered. However, the U.S. Preventative Services Task Force has not adopted that recommendation in individuals younger than 18. And so most primary care and pediatricians will not therefore screen unless USPTF makes that recommendation. So, kind of understanding how our colleagues practice is also really important. Next slide. This study was one where we looked at kind of school-specific data, and it was the first study to provide kind of a detailed national level estimates of past year non-medical use at the school level among U.S. secondary school students, so middle school, high school. It's a huge range, and the wide variation that we found indicates that schools need to assess their own student bodies rather than relying on regional, state, national data. And the variability was really incredibly zip code specific. Next slide. This is another MGH study looking at 300 college students, and kind of as expected, right? with stimulant misuse, the lifetime prevalence of any substance use disorder is over 50%. Next slide. So what can we do clinically to curtail prescription drug misuse outside of the context of ADHD or within? So number one is education, psychoeducation of adolescents and young adults about prescription drug misuse. So really knowing how common it is. Communicating about the medical, psychological, addictive, and legal issues of prescription drug misuse. Really in the setting of an active substance use disorder, trying non-stimulants or extended release prodrug stimulants. Not over prescribing. And we'll get into this in a minute, looking at some of the COVID data. So oftentimes to minimize risk, I'll ask patients, like if we have a trial of a medication, it's really not a good medication, I'll ask them to bring in that medication so that we can move on to the next controlled substance when they pick it up at the pharmacy so that there's not supply sitting around. Safe storage, I typically recommend a digitally locked medication storage, and that's really important as these kids go off to college. And also a lot of coaching on don't advertise that you're on stimulants. This is your medication. You need this in the setting of ADHD to prevent diversion and then that patient not having their medication. Next slide. So let's go one more. Let's talk about some trends. So this is kind of looking at specifically MTF data on what happened during COVID. And what we saw was an uptick in stimulant use that you can see in the green line, which is the green line is stimulants and non-stimulants. Red is non-stimulants and blue is stimulants. And the majority of the uptick was from increased stimulant use during COVID. Next slide. And here's the number. So this is stimulant and non-stimulant, kind of an uptick of almost 5%, just under. Next slide. The majority of which is accounted by prescription stimulants. Next slide. Non-stimulants were really a fraction. Next slide. So IQVIA data was published by the DEA, and the DEA is very interested in who's prescribing what. And I think this data we need to be aware of to help support our nurse practitioners and APPs. And what they saw in this publication that came out in August of 23 was that 75% of all stimulant prescriptions between 2012 and 22 were prescribed by psychiatry, which is the top line, followed by pediatrics, which is the next line. Then the next line is family practice is the blue line. But there was an uptick of about 500% in nurse practitioners prescribing controlled substances. What this data doesn't have is, were these nurse practitioners embedded in psychiatry or family practice, and were these unstable patients? And they, so I'm so worried that this data is going to be used negatively against some of our prescribing colleagues, that I want to make us, the research community, really aware that maybe this is something we really need to look into more, especially if the DEA is pushing out these numbers. Next slide. All right, so let's talk a little bit about diversion. Next slide. So diversion pre-COVID really largely was about 56.5% of non-medical users were given the stimulant by a friend in 2009 to 2011. Next slide. Over COVID, though, it changed to not from peers, but using one's own leftover prescription that they had still stored. Next slide. And then the second most common pre-COVID was I bought it from a friend. And then this transitioned into a significant decline during COVID because there was no access to friends. Next slide. So in this study, we looked at, again, some multi-cohort panels, about 12,000 of US 12th grade students, self-administered questionnaires at baseline, and followed them prospectively over 6 years into young adulthood. And the main interest was adolescents' use of non-stimulant and stimulant medications for ADHD and later risk of non-medical stimulant use. And we included cocaine and prescription stimulants in this study. Next slide. And what we saw was that when adolescents use their stimulant therapy for ADHD as therapy with no previous history of medical misuse, we saw they were almost like controls. They had no associated increased risk of non-medical stimulant use or cocaine use. When adolescents used non-stimulant therapy for ADHD and took it and no history of non-medical use, it was also protective. So both can be protective when used appropriately and early. And then finally, there was support that adolescents, even if they used both. So, because there was some question, well, is ADHD, when they're treated both with combination therapy with non-stimulants and stimulants, a more severe form of the disease? And then is there more risk? And we did not find that. Next slide. And this is really, again, just kind of another study looking at about 130,000 samples, 16 cohorts, which again just takes this data and pieces it from multiple, like looking at a diamond and looking at all the facets. So early onset of ADHD, long duration of stimulant therapy use taken as a medication makes the risk of cocaine and prescription stimulant misuse about the same as control. So it's protective. Now it changes if they start 8th grade or beyond, meaning the risk of developing these disorders increases. It doesn't mean you don't treat, but it means you need to be aware of that. And then kind of intermediate duration has, intermediate risk levels. Adolescents who start, like I said, in 8th grade, not only was it for prescription stimulant misuse and cocaine, but we also saw increased rates of methamphetamine use. And again, this is where the USPTF data and I would say our work disagree on screening. Next slide. The next slide. I'm just going to I think to me, this is by far a more important slide. And at least on the clinical side, what we see is that even though, for instance, prescription stimulants and cocaine act very much on your brain similarly, meth really has a little bit of a different severity. And so not all stimulant use disorders are created equally. And cocaine, so this was 2015 to 2019 NASDA data. We looked at about 282,000 past year use patterns. And what we wanted to really highlight in this data is that illicit methamphetamine and polysubstance use have significant higher prevalence and adjusted odds ratio of severe stimulant use disorders. And this was really a deeper dive into severity and what use patterns look like. Next slide. So it's a lot of data, right? A little bit about ADHD, a little bit about substance use disorders in general, a little bit about stimulant use disorders, but I think this is probably the summary, right? So We know ADHD is a risk factor for especially smoking and vaping and cannabis use disorders, as well as other substance use disorders. Teenagers and young adults with ADHD should really be looked at, I think, when we're clinically providing expert level care in the substance use disorder for both potential problems. ADHD should be considered in adolescents and adults who just smoke, vape. That treatment helps protect against the onset of smoking, substance use disorder, and substance use disorder related criminality. I didn't go through those studies. And so counseling parents, especially 7th grade and earlier, that treatment can be protective, I think is important. That we need to use strategies for management of substance use disorder and use disorders in ADHD that are a little more intensive and a little more digging of collateral, and really did the ADHD start before the age of 12? And then thinking about, in our high risk groups, mitigating strategies like using extended release stimulants, a lot more psychoeducation and monitoring. It is not uncommon that I have young adults with ADHD who go off to college who want 90 days of stimulants because it's hard to get, and really helping the family and the patient understand why it's important to engage at their school, why it's important to only get 30 days at a time, why if their medication is diverted by a roommate, then they really struggle getting their medication. So next slide. I think through the lens of this work, if I could only ask a patient one question, just one question, to really try to stratify risk and how I think about it, next slide, then my question in the most non-judgmental way would be, hey, have you ever used a stimulant that you got from someone else or used it differently than was prescribed? Like used your own Adderall a couple times a day because you're tired or you had too much going on, and then ran out early. That would be the question. Next slide. This is our research team. Just want to give mad props to them. Next slide. And then in this talk, and we're happy to send this talk out, I just really included some kind of genetics, environment, ADHD slides that I often share with patients and their families. Oh, next slide. And then one more about neuroreceptors, next slide. Because I think it's just helpful for us to remember how complicated this disease is. Both substance use disorder, ADHD, and the interaction is far more complicated than either alone, and it's really more the norm. I think that's it. We lived through my Zoom snafus, and so I appreciate everyone's patience during the talk. It was not my best technology moment today. And thank you, Angela.
No problem at all. I mean, the content made up for it. It's totally fine. No problem. We all have our issues with Zoom. So if anyone has any questions, feel free to go ahead and ask or put them in the Zoom, and we can have a discussion.
I think the other thing, if I'm just going to point something out, I hope most of you know that ASAM put out stimulant use disorder guidelines at the end of last year. And, one concern for me at least ASAM state of the art was, Brian Hurley, who's the president of ASAM, really talked about the stimulant use disorder guidelines. And they are not treating stimulant use disorder with stimulants. That's not, but for some of the members in the audience, and there are others who feel like, well, maybe we do this like we did with Suboxone, right? But the risks of using stimulants, especially in some of these settings, are they have much higher rates of psychosis, right? We know psychosis on the brain takes a lot longer to recover. And so I think clinically, at least at ASAM and AAAP, among clinicians, and even at EMERSO, which was just not too long ago, there is a lot of back and forth on what should we be doing in populations with pure stimulant use disorder, and should we be considering MAT, and what does that look like? I clinically, I have very mixed feelings about it. I do have a couple patients that I have done it with that have been very successful with it. And thank you, Angela. Yeah, there is no standard treatment. The standard treatment for somebody with a pure stimulant use disorder, right, without ADHD is contingency management, right? That's the best data. If they have ADHD and active meth use disorder, oftentimes the data is there for either naltrexone and Wellbutrin. There was a randomized control trial on that, but it's very rare that we will start a stimulant at the time of an active meth use disorder, particularly in the complex patients in the hospital. They are just too sick and cognitively impaired, right? And so the guidelines suggest that potentially addiction docs or addiction psychiatrists should consider it, but it is an off-label, non-FDA approved use, right? So it is not in the guidelines to use Vyvanse or Concerta outside of somebody with both ADHD and a meth use disorder. If they have ADHD, for sure, you can try it. But the question is, can you see the patient often enough to follow them up? It's really about engagement in therapy. And in that situation, many of us do it.
I do have a question. Have there been studies that have looked at long-term use of ADHD medications and potential negative effects of that? Is it something that you would think that the patient, if they are benefiting from it, they could potentially be on it for, decades perhaps, or is it something that should be more time limited that they should eventually wean themselves off of?
Yeah, there's no really great studies on that in general, right? If you think of ADHD as a neuro developmental disorder, right, with a kind of hypodopaminergic response, right? I think methylphenidate has been shown to decrease rates of dementia. Like, there's like little pieces, but they're not great causal studies. As the mother of a child with severe ADHD, this is how I got interested in kind of this space with Sean. It is so clear the impairment level, and as I see patients of older ages, how it changes, that I think it's about clinically indicated use, right? So, we use cancer meds now long term, right? For breast cancer, for colon cancer, people are on them for years and years, even though there's some risk to that to other organ systems. And I think with ADHD, we know there are some cardiovascular risk factors, but to have a pure study where we don't have all this messiness involved and being able to really stratify out, like, is it the substance use disorder that's really changing their cognitive impairment? It's impossible. It's just so messy to answer that really well, Megan. It's a great question.
Angela put another question in the chat. Can you talk more about someone who is diagnosed with ADHD, but they might instead have low-level autism? Would the use of stimulants to treat the ADHD cause further issues, increased risk of substance use disorder?
Yeah. So I think clinically the perspective is treating both, right? So it depends on, is there comorbid conduct disorder? Does the stimulant help or does it make it worse? What happens at kind of when the stimulant wears off in this complicated dance? We definitely use stimulants in this level. I would say the norm is typically, especially with the low needs autism, to use a lot of Intuitive and clonidine before dialing in a stimulant, because people don't tolerate the anxiety from the stimulant or the behavioral dysregulation. And combination therapy seems to decrease the amount of higher dose stimulants, and it's more tolerable to the patient. We don't know about the increased risk specifically in those comorbidities. There's no really good study in that I've seen, at least. And if somebody knows differently, please chime in so we can all learn. What is the standard treatment? Oh yeah,
Oh, no,
sorry.
I was
Were
just saying
you?
it'll be interesting with more studies looking or more researchers looking at ABC study data, thinking about these like developmental issues, looking at individuals. I think Alex Weigard has done some work on ADHD symptomology in the ABC sample, and it's a non-clinical sample, but it's large enough that there are, subsets within that sample, that do meet criteria for, autism spectrum and ADHD. So it might be interesting. I was thinking of this question of like looking at kind of developmental and like, kind of might be able to address some of more of those causal, like which came first issues, like you were talking about.
Yeah, there was one trial for looking at, and I saw the pre-published prints on it, that the group at Mass General did for people who are hospitalized with a meth use disorder, but didn't look at it. It was called the meth trial, and they used a long-acting Librium, Seroquel, mirtazapine, and Benadryl just to treat meth use withdrawal, and retention in treatment and engagement had some success. It was incredibly small pilot study at 23 patients. Clinically, we often see that for people with meth use disorder, like the combination of Remeron and Seroquel, as they're really trying to work on that, and some clonidine to help mitigate withdrawal. And then also, I don't think we use enough acidification, either vitamin C or teaching people with comorbid substance use disorders and ADHD who are on stimulants, to, at the end of the day, drink some orange juice to help you get through that period, that transition period where the stimulants are wearing off, because the stimulants are alkaline salts. And so acidification can kind of help that like little mini withdrawal period that people often refer to as the witching hour. And in the MGH study, they actually used BID vitamin C in people in methamphetamine withdrawal, which was interesting.
Well, if are there any final questions? No, if not, unless you have anything else to finish up on, Vita, but I really, again, we really appreciate you talking today about this important issue. And, I think there are I worked on monitoring the future data for a long time when I was in grad school, and it's a phenomenal resource that is available there. And there's a lot of great publications coming out with MTF data and ABC data that are address some of the topics that we covered today. So I would definitely follow along with those to stay up on this area. All right.
Oh, thank
Well,
you. Thanks so much for having me.
yes, thank you. All right. Thank you again for coming. And our next UMATS Lunch and Learn will be in April. So look for flyers and information about that will be sent out very soon. Right, thank you, everyone.